don't see my notes. And then if I do this, you see my notes. You see my notes?
Yes, we can.
Okay. All right. That is any other way to.
You have to click on the last icon. Okay, yeah.
Yes. Okay, let's do this. Yeah.
We'll start.
Yeah.
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 So good morning, good evening, everyone. All those who have joined us for this next lecture in our series. It is my pleasure to introduce our very esteemed faculty for today. Our chairperson, Dr. Shivani Sharma. Dr. Sharma is currently the Director of Laboratory Services and the Vice President of Pathology at Core Diagnostics, Gurgaon. A gold medalist in both her diploma as well as DNB. She has authored over 50 peer-reviewed publications in various reputed national and international journals. Dr. Sharma also has delivered numerous platform and poster presentations at major oncology and pathology conferences, including the US CAP, ICC, and IAPM. We are truly honored to have her today to chair this session. Over to you, Dr. Sharma.
Thank you, Dr. Anandi. It's an honor to be here and to introduce somebody about whom I've heard so much from Dr. Mohanty himself. And because the names were the same, so it always had a resonance. So the speaker for today is esteemed Dr. Shivani Kandukuri, completed her residency in anatomic and clinical pathology at Cedars-Sinai Medical Center and subsequently pursued a genitourinary pathology fellowship at Brigham and Women's Hospital in Boston. She has since served on the faculty at the University of Southern California for over 6 years and currently leads the genitourinary pathology division at the University of California, Irvine. Dr. Kandukuri has authored multiple peer-reviewed publications and is deeply committed to medical education. Her academic interests center on genitourinary pathology, particularly of the testis and kidney, and she is slated to teach several short courses on these topics at USCAP in the coming years. Over to you, Dr. Shivani.
Hi, good morning. Can you guys hear me?
Yes, we do.
Yes. And you see my screen too?
Yes.
Okay. Hi, Shivani. And as you said, I have heard a lot about you also from Sambit. And I'm really happy and honored to be here. And I would have never thought when I met him for the first time in 2011 as a resident at Cedars-Sinai when he was a surgical pathology fellow that this day would come where I would have to
Slides
talk.
are not moving.
Yes, it's not moving. Yes. Okay, I didn't move them. So as I said, when I met him in 2011, I did not think that this occasion would come where I would have to speak at such a somber presentation. But here we are. This is the last time I saw him at the USCAP in New Orleans, and this on the left is a picture of Sambit with mini Cedars reunion. This is Snehal, Dr. Snehal, and that's me and Dr. Frischberg. We were all faculty
Your
together. We
slides,
are all,
we can't see your slides. There only first slide is visible.
correct. I'm only talking about the first slide. I'm only talking on the first slide. I'm not moving it. Is that okay?
Yes, ma'am.
Okay, I'm going back to this. I was just saying that this was a mini Cedars reunion on the left. We were all from Cedars and...
Excuse me, ma'am. That slide is not visible.
Yeah.
Where Sambit sir is there, that slide is not visible on your screen.
You are able to see the one with Dr. Agul?
No, we are not able to see anything. It's just the title that is visible.
Oh, that's very strange. Can you see it now?
Yes, ma'am. Thank you.
Okay. Maybe I'll have to leave it like this then. I hope it's not. What about this slide? Can you see everything?
Yes, we are able to see. We are able to see.
Oh,
Right.
So I think only this photograph is not. Okay, so yes, a mini reunion on the left with all of our Cedars, some of our Cedars folks, and on the right, this was at the beginning of the meeting with Dr. Agul. Sambit and I had a couple of posters and a platform that year. And, it was always a joy to work with him. He would always wake up at odd hours and give me a call and say, "Hey, I have this idea and let's work on this. And what do you think about that?" So it was very inspiring last 14 years that I have known him. And it's very unfortunate. And as we all know, it was very early for this to have happened. Anyway, in honor of Sambit, here we go. Um, this is pretty much the outline of the talk that I'm going to be giving today. And we'll start. It's a case based assessment of germ cell tumors, of treatment naive germ cell tumors. So I'm going to speak most only about testicular tumors, and some portion of my talk will be about metastatic um, testicular tumors, but mostly it is of untreated testicular tumors in their naive condition. Just a quick demographic details. On the left, you can see the first graph. Here, most of the peak of patient populations where you see germ cell tumor are seen in Northern Europe. And as you can see here, there is a spike over the entire world in Northern Europe. There are genetic factors weighing on this population. And on the right, in the middle, you see a second
Slide is
graph
not
where
moved, ma'am.
oh, it's I'm
Dr.
sorry,
Shivani,
I'm so
yeah, we are still on the outline slide.
okay. Now
No.
I don't know what's happening.
Yeah.
Now
Yes,
you
yes,
see the screen.
yes.
Sorry, I really don't know what's changed. So I'll just stay here then. And so as you can see here, I was saying the European ancestry is a major risk factor, and the germ cell tumors in patients who have a family history is about 4 to 10 times um, increased risk. In the middle, there's a chart that shows the incidence of germ cell tumors in the life of male patients. There's an initial spike in the infant group, and that is typically seen between the ages of between the ages of 1 and 3. And then there are no germ cell tumor, there's no germ cell incidence in that age group. And then there's a second spike that is seen typically in teenage years and early adulthood, and kind of weans away towards middle age and older patients. The second spike is your major patient population of the germ cell tumors that have the germ cell tumors, and the overall incidence of germ cell tumors is 6 cases per 100,000 males annually. And the last graph shows us the age distribution. And as you can see, the red is the non-seminomatous tumors, which occur at least a decade sooner or earlier than the seminomatous tumors peak. Okay, now I'm moving on to the next slide. Okay, so can you see the slide? Now, can you see the slide?
Yes, we can.
Sorry about this, guys. I don't know what's happening, why it keeps skipping stuff. So this is a nice image I use from the Lancet paper that I've on the top here. It just quickly shows us we see this is the primordial germ cell, and when there are abnormalities in the maturation of the primordial germ cell, the infantile germ cell tumor arises. This is the first spike of germ cell tumors that we see in infants, and in those it is an abnormality with the primordial germ cell. And typically in the infantile germ cell group, you see pure teratomas, prepubertal teratomas, and pure yolk sac tumors. This is very rare, but you do definitely see it in this subset of patients. And then this matures, the primordial germ cell matures into the gonocyte and then into the spermatogonium. So at this phase, when there are abnormalities, genetic abnormalities, or physical abnormalities like cryptorchidism and other dysgenesis, gonadal dysgenesis. There is arrest of differentiation, and this leads to the formation of a delayed gonocyte. And over time, the delayed gonocyte acquires more abnormalities and mutations, and gains some expression of the pluripotent factors that we take advantage of for our immunohistochemistry. And these overexpression and gain of even the isochrome 12p gives rise to the GCNIS cell, which is a germ cell neoplasia in situ. So a patient may be born with a delayed gonocyte, but there are other environmental factors and puberty and hormones that have to impact and be a double hit, when after which the GCNIS cells kind of express themselves. And when the GCNIS cells get reprogrammed with additional mutations, they give rise to the non-seminomatous components of germ cell tumors, which are the embryonal, yolk sac, choriocarcinoma, and teratoma. And if the GCNIS cells proliferate as is, as you can see, they give rise to the seminoma tumor cells. So we have the germ cell tumors are composed of seminomatous tumors, seminomas, and non-seminomatous tumors. And they can be pure, typically is a pure seminoma, and typically the non-seminomatous components can be in a mixed germ cell fashion. And this is what we are going to talk about mostly today, and what we see on the regular in an adult hospital. Quickly, a comparison of the 2016 fourth edition and the 2022 fifth edition. Over the years, we have seen that the molecular progression has allowed for a finer classification of these tumor cells, but the main classification is based on the presence of GCNIS in the adjacent
Dr.
testes.
Shivani, the slide has not moved.
It's not moved. Okay, I cannot predict when it's moving and not, so I'm just going to stay on this mode. And you can see the understanding of classification has improved with the molecular, as I was saying, and the main classification is based on GCNIS and lack of GCNIS. So this is the algorithmic approach. I'm coming to the algorithmic approach that I use, but this is a basic classification. Again, for the folks who are attending the testicular talks for the first time, most of the testicular masses are germ cell tumors. So that's what you will be seeing most of the time. And that is on the left. You can see GCNIS is the precursor for these, including the teratomas with secondary somatic malignancy, and trophoblastic tumors, which are the choreo, and the non-choreo, which are the PSTT, placental site trophoblastic tumors, epithelioid trophoblastic tumors, and the cystic trophoblastic tumors. My talk will focus mostly on CTTs, because PSTTs and ETTs are seen in the post chemo setting. So I'm not going to go into details on those. The other two tumors that are also seen and come under the germ cell tumor category are the spermatocytic tumor, which was previously known as the spermatocytic seminoma. And as molecular development has occurred, they have realized that this is not a seminoma and does not share any genetics with a seminoma. The other common, I say, but other less common tumor is also rarely seen is the gonadoblastoma. And the other smaller subset of tumors, less than 5%, are sex cord stromal tumors. We frequently do run into a Leydig cell tumor, Sertoli cell tumor, but rest of the tumors are really rare. And then the other masses that we see, especially in older patients, when you have an older patient, 45 years and above, 50 years and above, you have to always suspect lymphoma, especially when there is a testicular mass with generalized lymphadenopathy, which can look very much like a primary testicular mass, and with metastasis. Also, in older patients, must exclude extension of a liposarcoma into the testicular site. This is a quick tabular form. I won't go into too much detail, but just to highlight for the newbies. As I said, seminoma occurs a little later, a decade later than non-seminomatous The tumor markers are critical because any patient that comes in that age group where you're suspecting a germ cell tumor, the first move is to gather the serum markers, and typically is the LDH, HCG, AFP that are critical in our evaluation. Seminomas have elevation of LDH and a mild elevation of HCG only when they are associated with syncytial trophoblasts, and they should have a normal AFP because there is AFP secreted by yolk sac tumor, and that is not something we see in a seminoma. Again, in non-seminomatous, you can have elevated HCG, and when I say elevated, it has to be over 50,000, 100,000 units, which means there is a possible choriocarcinoma component. Elevation of AFP would be a result of yolk sac tumor, presence of yolk sac tumor. Seminomas are slow growing, whereas the non-seminomatous, which occur decades sooner, are more aggressive.
He's
Uh,
presenting, so you will see it. Better to see that.
sorry, what? Can you hear me?
Yes, yes. No, we can.
Yes. Slowly growing, and metastasis tends to be more localized. The pure seminoma tends to be more localized and spread via lymphatics versus
As usual.
non-seminomatous, which spread via blood or hematogenous spread, and tend to spread sooner than seminomas. Key factor that we use in management is highly sensitive. Seminomas are highly sensitive to radiation, versus non-seminomatous tumors are resistant to radiation and do better with chemotherapy. Overall, the germ cell tumors, seminoma being the poster child, has excellent survival, especially when it is caught at an early stage, because it is very responsive to chemotherapy. Again, germ cell tumors are seminoma, and non-seminomatous tumors are embryonal, yolk sac, trophoblastic tumors, and teratoma. Okay, so this is a quick comprehensive, I like to say, life cycle of the germ cell tumor. So for whatever reason, the patient is, has a family history, is Northeastern ancestry, cryptorchidism, gonadal dysgenesis, all of those issues can lead to a testicular mass. And as I said, 95% of the germ cell tumors arise from GCNIS. And so what typically happens with these tumors is 70 to 80% of them are identified in the stage 1, where they are limited to the testis, and an orchiectomy alone is pretty curative, uh, where about 99% of the patients are cured either just by the orchiectomy or maybe some adjuvant therapy. And then 20 to 30% are identified in this metastatic stage, where they're stage 2 or 3 with testicular tumor showing LBI. And in these patients, they require additional chemotherapy and RPLND, and they do reach a cure rate of about 80 to 85%. Either stage 1 or stage 2, there's a small portion of patients, 5 to 10%, who are at higher risk that develop relapse. We'll discuss the risk factors later. And this is unfortunate, but it also is pretty responsive to further management like chemotherapy. Most most common site of metastasis, typically the initial metastasis, occurs to the retroperitoneal lymph nodes, and other common sites, especially if it's a choriocarcinoma, lung is pretty frequently the site where they metastasize. Also, tumors can metastasize to the liver and brain in advanced cases. I'm not going to go, I already gone through this pretty much, but beta HCG is elevated in higher concentrations in choriocarcinoma and over 100,000 in advanced cases. Seminomas with only syncytial trophoblast cells have a mild elevation that you can see about 50 to 500 units. So when I have a case where I have the serum markers and the HCG is 250 units, I know we are dealing with a syncytial trophoblastic proliferation within the seminoma or embryonal carcinoma. Syncytial trophoblasts can be identified with any of the germ cell components, but they're typically seen in seminomas. They can be seen with others, and they have a mild spike in HCG. So I make it a point to find the syncytial trophoblast and put it in my report, because otherwise I get a call from the urologist asking, oh, I saw a spike in the beta HCG. why is there choreo? So then I explained that the small increase in beta HCG is only because of the benign syncytial I mean, not benign, but syncytial trophoblasts that are not a component of choriocarcinoma. LDH is elevated, as I said, in seminomas and is highly increased in advanced stages. Alpha fetoprotein is a marker of yolk site differentiation. And one of the newest ones, which are still in trial phase, are the micro RNA, especially the micro RNA 371, 372, 373 family. And these are expressed in seminoma and non-seminomatous tumors except teratoma, and they are detected with greater sensitivity in the blood. And these are really helpful in patients who have undergone recent orchiectomies and RPLNDs, and almost in real time can, um, you know, show us the incidence of the recurrence of tumor in patients who have recently undergone surgical procedures. Again, this is a staging system that CAP uses where they stage based on the serum markers. And this is something that helps refine the staging system when you add this um, another entity into the staging, which is different from the physical, gross, and histologic staging. So this has been found to be helpful and is used in the CAP synoptics when we do the synoptic forms. Quickly, a comparison between the 7th AJCC and the 8th AJCC staging is we are all aware of the GCNIS being in site 2, and then the involvement of testis epididymis in the 7th edition. But the difference in this is in the 8th edition, the seminoma, only for seminomas, the size became a matter where we could split them in less than 3 centimeters and more than 3 centimeters. And then PT2 always, LVI is something that and involvement of hilar soft tissue, something that we have seen newly in the 8th edition. And in PT3, the term for spermatic cord, if you want to see the continuous involvement of spermatic cord versus discontinuous spermatic cord involvement basically indicates that the tumor is aggressive and there is LVI, or just discontinuous involvement through LVI of the spermatic cord, which upgraded it to M1, which is metastasis 1. So you want to take a clean margin of the spermatic cord, and then you also want to take the proximal and the mid and the distal sections to see if there is tumor involvement in a continuous or a discontinuous fashion, because that is now going to affect staging. Quickly, a review of the anatomy. You want to appreciate the two layers, that are the outer vaginalis and the inner albuginea. And then these are the seminiferous tubules, which are coiled. And then all of these tubules um, drain into the rete testis. As you can see here, rete testis is the point of least resistance, because all around you have the tunica, versus this area you have no tunica, and this is kind of where the tumor invades into when it is growing. The rete testis is epithelial. It is a keratin positive structure, and this drains into the epididymis. And the epididymis has the head, body, and tail, and this forms the vas, and this joins the spermatic cord structures. Again, the seminiferous tubules form the spermatogonia and the spermatids, and they drain into the rete testis, and the rete testis collects and pumps it into the epididymis. And this is a very muscular structure that continues as the vas. Here is the hilum of the testis, which includes the rete and the hilar soft tissue, and this is becoming increasingly important in staging. And so we always want to take a nice section when we bivalve the testis to encompass this area. That way we can look for tumor involvement in this area. Again, this is the testicular anatomy in real time, and here you can see the spermatic cord. This is the hilum. This is the testicular parenchyma, nice and brown tan. It is pretty uniform. This was a case of I think gonadal dysgenesis. So I'm sorry, gender dysphoria. So we have a tumor without a testis without any lesions. This is the fat, the hilar fat that we want to appreciate in our sections. And if there is a tumor and it is involving the hilar fat, that is definitely something that increases the risk for a patient of recurrence and high grade, high stage. Um, this is a nice picture I thought of the GCNIS. So GCNIS is again the basis from where the basic tumor cell, from where the germ cell tumors arise. They are limited to the seminiferous tubule. So right in the center, you can see a beautiful seminiferous tubule. You have a thin basement membrane around it. You have the outer base, the Sertoli cells, and then the pre-spermatogonium. And as they mature towards the lumen, you see the spermatids. So the growth, the spermatogonial niche is out here at the basement membrane, and they mature towards the lumen as and form spermatids. And in this GCNIS, again, you can appreciate these large polygonal cells with clear cytoplasm. The clear cytoplasm is because the glycogen was dissolved in the processing. And then you have these really high grade nuclei with very prominent irregular nucleoli, and are all located in the spermatogonial gonal niche, which is basically around the basement membrane. You can also appreciate how thickened the basement membrane is in the tumor GCNIS containing seminiferous tubules versus the normal seminiferous tubules. So when I look, and on the outside, you can see right here are the pink polygonal cells, which are the Leydig cells. So Sertoli cells on the inside, which are considered like the mother cells, and the Leydig cells are on the outside. Again, the GCNIS is always close to the basement membrane because there are other um, cells that can mimic the GCNIS cells, but they are typically these large cells that are closer to the lumen and do not have any atypia. GCNIS cells are towards the base in the spermatogonial leash. And again, when you have GCNIS, you have the tubules that can show atrophy, microlithiasis. GCNIS does have the 12p alteration, and it gets marked by the OCT34, CD117, D240, NANOG, SOX17, all markers of seminoma, because GCNIS cells basically proliferate to form seminoma, and when the GCNIS cells get out into the interstitium, is basically seminoma. So OCT34 is a really helpful stain, and I'm going to go over some of the immunos that we use. Again, very thickened basement membranes, atrophic, tubular atrophy. And here you can see the SAL4. Again, it's in the basal basement membrane pattern. Again, OCT4. Both of these are nuclear markers, transcription factors, so we really like using those. Another more popular stain, which we have used for so long, is the CD117, which is the classic, has the membranous staining. Again, you can appreciate it is in the basal basement, adjacent to basal membrane in the spermatogonial niche location. Okay, so I'm jumping into my case one. As I discussed, most of these is a 34-year-old male with a testicular mass. You have elevated LDH with a mild elevation of beta ACG. The first step is to get the serum markers and then do an ultrasound which revealed a 3.5 centimeter homogeneous mass. A CT pelvis and abdomen is almost always done concurrently for looking for any possible metastasis. There were no lesions identified, and the plan was to go ahead with an orchiectomy. Here you see a bivalve testicular tumor. Pretty much the tunica is maintained, but there is a very fleshy tan brown mass, a little bit of hemorrhage here and there. It looks like it is kind of impinging on the hilar area, so that's a very good area to take a section. It looks homogeneous, so I'm expecting it to be just one type of tumor, but you can always find something else. Tumor, this is pretty low power of what the tumor looked like. Pretty much the same uh, homogeneous tumor in all of the sections. Again, this is a discohesive, clear cells, very prominent hyperchromatic nuclei with nucleoli, and these are the clear cells, and these are low power, which shows the second population. You have the clear cells that are sheet-like expansile growth with smattering of lymphocytes in there. So this has two populations. One is the tumor cell and the associated lymphocytes, and there is only one tumor that looks like this. This is the seminoma. This is the algorithmic approach that I want to take. I take for all of my cases. So when I have a When I have a testicular mass, I do not tend to do SAL4 because it is in the testis. There is really no need to do SAL4. I would do SAL4 in the metastatic settings. So I jump straight to OCT3/4 if I really need to do a stain. So some labs call it OCT4, some call it 3/4. So basically it's the same thing. If it is positive, then I know I'm dealing with a seminoma or embryonal carcinoma, and then I go ahead and do maybe one or two more stains if I'm really unsure. And typically we do the CD117 and T240. SOX17 and NANOG are not present in every lab, but usually the T240 and CD117 panel is sufficient. And when it is positive, nicely positive, we are confident to call it a seminoma. So this is pretty straightforward. It's a discohesive cells, two populations. OCT4 is nicely positive, CD117 is nicely positive. So this is a classic case of seminoma. And as I said, there was also an elevation of HCG, which I tend to go looking for the syncytial trophoblasts, and there they are, syncytial trophoblast cells singly floating around, not associated with cytotrophoblast, not associated with hemorrhage, because that would then start, I would start thinking about a choriocarcinoma. This is just by itself, syncytial trophoblastic cells. They are positive for SAL4, not great positivity, but they are positive. Beta HCG, as you can see, it is a junky stain. It stains the entire slide, but it does have a focus on the syncytial trophoblast cells. And a cleaner stain, which we use now, is the GATA3. That, it did not stain this syncytial trophoblast really well, but it stained this one really strongly. So I always make it a point to look for those. I'm jumping into a quick, this is not this case, but I also, how I use the OCT3/4 in case of RET testis involvement. This is another case, not this case, but RET testis is, as you can see, is, as I said, is an epithelial structure, and therefore it stains here with keratin. And here you can see that there were like clear cells lined on the RET. So I got an OCT3/4, and it showed the presence of seminoma cells, and which is basically the GCNIS cells that have tracked themselves.
और कुछ लोगों की डेथ भी हुई है, तो वो अभी हालात का जायजा लिया जा रहा है, और एग्जैक्ट फिगर जो है आप
Can someone turn him off? Yeah. So the OCT3/4 highlights the GCNIS cells that have tracked themselves from the seminiferous tubule and walked, kind of trekked their way into the RET. And here you can see a negative staining where the keratin stains the RET but does not stain the germ cell, the GCNIS cell. So this is just quick distraction from what the seminoma. So again, coming back to seminoma, we have the clear cells, the lymphocytes. This is classically called a fried egg appearance with the sesame seed sprinkled in there. And very frequently you see these tumor cells when they're really fixed well and the formalin has dissolved the glycogen, you get a nice image of a clear cell tumor, discohesive clear cells. With the prominent nucleoli, which I've used very often. The prominent nucleoli is a very important factor for me to be sure, especially in the metastatic settings that I'm dealing with a seminoma. Very commonly, 20% of the cases do show a very intense granulomatous reaction. I have a picture coming up later. A granulomatous reaction that is so exuberant sometimes that it kind of masks the tumor cells. And there was one case that I had where there was an 8 centimeter scrotal mass, and the first few frozen sections done on it was just purely granulomas and granulomas, which gave us a hint that we were probably dealing with seminoma. So granulomatous response is very exuberant in some of these germ cell tumors, typically seminoma. So do not be fooled that this is some tuberculous infection until you get an OCT3/4 and you find the tumor cells. Okay, next case. I'm sorry, this is the first sign out of this case. So I mention all of these in my reports. I talk about the type of tumor and the size of it, and then whether it is limited to the testis or it's involving the RET. For example, in this case, I guess it was this case. Sorry about that. It did involve the tumor via pagetoid spread. It did not involve the hilar soft tissue as it remained in the RET. There was GCNIs identified. We did not identify lymphovascular invasion, and I always inform the urologist about the maturing spermatogenesis status of this patient, because most patients before they have the orchiectomy do collect spermatids. Okay, so this is a case image of a case where you can see on gross how the tumor is pretty fleshy, uniform, another seminoma, and how it is taking over the rete testis. You can see the rete structure here, and the tumor is invading the rete. And this is a histologic image of that. Again, you see these tubular structures, which are the rete, and then the seminoma is invading the parenchyma of the rete testis. So we have two ways of involvement of the rete. One is by direct invasion, which I'm showing you here, and the previous one is the pagetoid spread, which I showed you with the previous case. So you have the pagetoid and the direct invasion into the rete. And in this case, again, the tumor stays at the rete. It is not gotten into the hilar soft tissue. So this one will not be staged, will be staged as PT1 still because of lack of hilar tissue involvement. So why is staging so crucial? Because patients who most of the patients, they, as I said, they do really well. They're pretty much cured by orchiectomy, but there is a subset of patients that have increased risk of relapse, which I mentioned here, which are basically the mass is greater than 4 centimeters. If there is hilar tissue invasion or rete testis involvement, this shows that there is an increased there's an aggressive tumor that is getting into the hilum, and then there is presence of lymphovascular invasion. For some reason, in increased beta HCG with scattered syncytial trophoblasts is also considered a high risk factor for relapse, and elevated AFP, which we typically should not be having with seminomas. So for all these tumors, the tendency is to treat after orchiectomy to give some adjuvant therapy. But the adjuvant therapy commonly given is the BEP, bleomycin etoposide platinum treatment regimen. And these are very cardiotoxic and pulmonary toxic. So most patients who had received this back in the 60s, 70s, and 80s ended up having to undergo the need for a transplant for lung or for lung or for heart. So the thought process was, why do we absolutely have to treat these patients with chemotherapy? So the tendency is to be very conservative. At least here, the tendency is to be very conservative and give chemotherapy to only the patients who have high risk factors, or at the time of reporting have a large component of embryonal uh, carcinoma. So if there is small component of embryonal carcinoma without any LVI and the patient has just a seminoma with embryonal, the tendency is to watch them, do the orchiectomy and watch the patient. And if there are any high risk factors such as these, they consider doing chemo. Or if there are metastatic nodules already, then they consider doing chemo. But otherwise, the tendency is to keep the patient as chemo naive as possible. So just to avoid these aggressive therapies and side effects of chemo. So again, this is a very large seminoma, gross image of a very large seminoma. Here you can see it is kind of obliterated the rete and the hilar area. And this is a high power of that. Here you can see there is hilar fibroadipose tissue here, and the tumor has crossed over from the rete and gone into the hilar soft tissue. And here, right adjacent here are the efferent ductules. And there's another image, gross image of tumor here, again taking over the hilum and epididymis. And here you see the tumor is right adjacent to the epididymis. And this is, of course, stage higher. These are really nice pictures of LVI. As you can see, these are critical findings that upstage the tumor to PT2. You want to see a nest of tumor cells away from the actual tumor mass, which is very hard sometimes, but you have to go away from the tumor mass and try to find these nests of tumor cells conforming to the space, and sometimes even adherent to the lymphovascular space. So that is a really good indication that we are dealing with true lymphovascular invasion. Unfortunately, this is something that I find it gets overstaged a lot. And LVI means stage 2, and LVI means the patient will be getting chemotherapy. So we have to take our diagnosis of lymphovascular invasion very seriously in this setting. So I want to give you guys this image and say, what do you guys think? Do you think it is a lymphovascular invasion when it is just the scattered nests in a vascular space? So for these kind of cases, when I'm not really sure and it's something that's not instantly coming across as lymphovascular invasion, I make it a point to look at the entire section. Here you can see the section has a lot of tumor cells floating around on the surface. This is basically what we call tumor butter, or just the artifact of tumor getting pushed when we make the slices. So you want to have a really well fixed tumor. You want to have tumor that does not have a lot of this artifact, because now this LVI is not believable. I don't believe this, and I would not call this an LVI in any condition, because there's a lot of tumor floating around. So not LVI in this case. Uh, okay, so another quick quiz here. So we have a tumor. Any thoughts on what this could be? It does not look very clear. It looks pretty aggressive with very hyperchromatic nuclei. It's very discohesive, falling apart. So the thoughts, I have gotten cases that have been called embryonal carcinoma, yolk sac tumor, or somatic malignancy, even like immature component of a teratoma and such when they're faced with this slide. What this simply was is an unfixed seminoma. All the stains pointed to it having OCT4 positivity, CD117, and the entire population, as you can see, is just one tumor, but not being fixed is so difficult to evaluate, because now all of the glycogen is not dissolved. The cells don't look clear anymore, and that is pretty much the definition of seminoma, is to be clear, have clear cells. So this was wrongly diagnosed as embryonal carcinoma and sent to us, and it was ultimately only an unfixed seminoma. So please be careful of the diagnostic pitfalls. This can be very simple if it is just given time to fix overnight, and uh, when it is bivalve, we do our due diligence and allow it to uh, fix as required. Again, lack of fixation, we do not see the clear cells because the presence of glycogen now. And then there is a lot of floaters when you have something that is not fixed, and then the LVI gets really messed up. And the last thing is, when you don't fix it well, the antigens for IHC studies are also really not expressed well, and so the immunohistochemistry is also affected. So I would say really take your time with the seminomas, with the tumors, and bivalve, and keep them overnight if possible. So then another question. So this tumor, it definitely has clear cells, and it is pretty discohesive, but although it looks a little different here. So any thoughts of what this could be? I'll give you a clue. We did the Salfor, and the Salfor did stain, but just not as strongly and effectively as it does for the seminomas, which is the differential diagnosis here, is seminoma versus this tumor. We did the OCT4 and it was negative. So at this point, I was like, it is not a seminoma. And then a newer stain is being performed on these tumors, and it was the SSX CT, which is basically a stain that antibody that works on the antigen at the conserved C-terminal region, and this stain is SSXT, and this tumor is spermatocytic tumor, and this is a newer stain that's being utilized for this tumor. Again, coming back to this chart, just to show you where spermatocytic tumors land. Here we have the delayed gonocyte, which gives rise to GCNIS. We are now dealing at the spermatogonium stage. So this is pretty much close to maturity, but when the spermatogonium acquires mutations, FGFR, HRAS, and clonally expands, it gives rise to spermatocytic tumor. So this is typically seen, is the narrative is that it is seen in the older patients, but honestly, this can be seen in younger patients as well, younger as in 30s, 40s. I read some articles on these tumors occurring earlier. So you want to be careful about not diagnosing these as seminomas. Going on, again, spermatocytic tumor in this algorithm, you get the OCT4. It is negative, but you see the CD117 will be positive. I did not have an image of that. CD117 is positive. So please consider getting a panel, always OCT4 with CD117 with D240 if possible, or at least OCT4 and CD117. when the octreophore does not stain, you will think of another entity like spermatocytic tumor. Quickly, spermatocytic tumor, it is older males um, is where it occurs classically, but it can occur sometimes in younger males too. So do not disregard this in your differential diagnosis. It is a slow growing non-metastasizing tumor. Has excellent prognosis, and as I said, it does not arise from GCNIS. It does not. It has a three populations of tumor cells: the small cells that resemble the spermatogonia or lymphocytes. It has an intermediate cell, and very famously, it's called the intermediate cell has the spireme like chromatin, and then giant cells or bizarre cells which are not seen here. So spermatocytic tumors are always in the differential, but they are super rare. I wanted to shout out this paper from our very own Dr. Mohanty, um, which is something that is seen typically incidentally or in autopsy cases or in patients for infertility. This is pure intertubular seminoma where the seminoma is just present in the interstitium and it does not form a mass. So typically this is not seen in our everyday tumors. These can be seen also in adjacent to large tumors sometimes, but PITS is something you reserve for tumors that are present in the interstitium only and do not form a large mass. Another All of these are pretty much small terminology things that pathologists like. I think I do not report this, but this is something that is in the literature, so I thought I'll touch on it. When you have a germ cell tumor, I mean a seminoma limited within the seminiferous tubules, and in this case you can see the seminiferous tubules are expanded, this is called an intratubular seminoma. So really, I don't make the diagnosis, but I saw it in the literature, so I thought I'll touch upon it. And you can have other um, intratubular forms like intratubular embryonal carcinoma, which looks different, which has necrosis and calcifications. I'll show you a picture of that later. But it definitely is something we can see in adjacent to a tumor mass. Quickly, the mimics of seminoma. Um, Primary testicular tumors, spermatocytic tumors, metastatic melanoma. As I said, granulomatous orchitis because these seminomas can also have a very dense granulomatous response. In the literature, there were articles on poorly differentiated carcinomas metastasizing to the testis and then medullary thyroid carcinoma. So I guess it has happened once in literature, so you can definitely think about it. Again, I'm not going to go over all these, but these are all the pitfalls. I would like you to always remember: get a panel. Do not rely on one stain because, as you can see, OCT4 can be positive in a small subset of lymphomas. SAL4 is expressed as well. And then CD117 just in the metastatic setting can stain a bunch of tumors. So you want to get the panel SAL4 always in the metastatic setting, OCT4 and the other stains. And then OCT4 can also be present in some of these tumors that we see pretty commonly: squamous cell carcinoma, adeno, and paraganglioma. So then we jump on to the next gross image of another testicular mass. Here you can see hemorrhage. This is not fleshy, this is not lobulated and tan brown. This is a hemorrhagic mass. When I have hemorrhage in a testicular mass, I'm always thinking about embryonal and choriocarcinoma. So going on to this is basically the intratubular portion, which has necrosis, tumor cells, and calcifications. And this is intratubular embryonal carcinoma, again just of note to see some of these tubules in setting of adjacent to a mass. Anastomos and gland. So embryonal carcinoma has several different histologic patterns. It can look basically like carcinoma anywhere in the body. It can form glandular pattern. It can have sheets, solid sheets. But what you can really appreciate here is it is almost like a syncytium. You cannot tell where one cell ends and the next one begins, and they kind of merge into each other. It has that amphiphilic tinge of color. It's not like eosinophilic, or it's not really um, pink or blue. It is like has the purple amphiphilic look. And then it has the glandular pattern again. Sometimes it has that piano keys appearance, and sometimes it has a papillary architecture with fibrovascular cores. So embryonal has quite a few faces, and again the same algorithm. You you do the OCT4 and you come down to having positive CD30 cells, negative CD117, and then you're dealing with embryonal carcinoma. And as you can see, it can also be positive for keratins, just like any adenocarcinoma. Again, same point, you want to really separate these from maybe a very poorly differentiated yolk. You have the necrosis, the hemorrhage, and a very active mitotic count as well as apoptosis. So that is your embryonal carcinoma, and embryonal carcinoma is the one that has the poor prognosis. So we are very careful to identify embryonal and do stains to identify the actual percentage of embryonal, because when we report mixed germ cell tumors, you want to give them the numeric percentage of every component. Next one is a 24-year-old male. As you can see, this is a younger male, so I'm expecting a mixed germ cell or at least a non-seminomatous tumor. LDH is mildly elevated, and there was a testicular mass that was 5.5 centimeters with no abnormalities in the CT. Orchiectomy revealed this, which is a seminoma. I think definitely we will identified that as fleshy mass, along with the second component of necrotic and hemorrhage tumor. And a nice picture of that here you can see is again like an adenocarcinoma on the right with hemorrhage and necrosis, and on the left, I know the picture may not be so great, but it has the discohesive seminoma on this side. Again, OCT4 is positive in both, but CD30 is positive only in a membranous fashion here in the embryonal, not in the seminoma. So CD30 really brings home the point. Another pattern here, you can see the seminoma cells and the embryonal cells are wrapped up into each other, and OCT4 highlights both of them, but CD30 highlights only the peripheral embryonal, and the seminoma is wrapped I'm sorry, is wrapped around, the seminoma is wrapped around by the embryonal carcinoma. So these are different patterns. You can see tumors can be really intermixed. So really take the time and immunostains to figure it out. Another pattern that I see pretty often is the embryonal with yolk. This is what I see most commonly, and I'm sure you guys see it too. Is on this HN, you can see there is a dense growth and then dense proliferation of tumor cells, and then there is this loose tissue, loose cells present within this embryonal carcinoma, and you guessed it right, that's yolk sac. And you can highlight this with glypican, which is a nice stain for yolk sac. Again, yolk sac is a tumor that we frequently see in the post-pubertal setting, almost always mixed in with other germ cell components. It's very rare to see a yolk sac tumor uh, all by itself in a post-pubertal setting, and in the pre-pubertal setting you will see pure yolk sac tumors. So again, these are stains that are OCT4 where they highlight the embryonal, it does not highlight the yolk in the background. And in the CD30 here again highlights the embryonal, and here OCT4 highlights the embryonal but does not, and the glypican highlights the yolk sac and does not highlight the embryonal in the background. Another image, again, both of these tumors are highlighted by keratin. So watch out for that. Keratin can highlight yolk as well as embryonal, so that could be a pitfall. But if you get the OCT4 with it, it delineates the embryonal carcinoma component. So this case was signed out as mixed germ cell tumor with percentages of all three given, and it was involving the testis. I'm sorry, it was invading the testis. Rete testis, and there's GCNIS, no lymphovascular invasion, maturing spermatogenesis is present. And then the next, there was a case where the tumor had metastasized to the lymph node, and here you can see there's a very dense granulomatous reaction around the tumor cells. This tumor was embryonal. It is classically described granulomatous reaction with seminomas, but as I said, you can see it with other tumors. This was an embryonal with a dense granulomatous response. You can see the granulomatous response in the testis as well as in the lymph nodes. Okay, now coming to the famous mimicker of germ cell tumors. So yolk sac tumor is something that has several phases, and my tendency is to do a stain, especially if I'm wondering if this is yolk sac, or sometimes it can look like an embryonal when it is really high grade. So yolk sac, as I said, several phases. It has a reticular or cystic pattern, glandular pattern, solid pattern. It can be clear, really clear, can throw you off, or sometimes in a core biopsy, maybe for a seminoma, it can be papillary. And then this is an image shared by Andrea Costa. He appreciated the signet ring cell pattern as well in the yolk sac. And this is another image by Andy. Especially the sarcomatoid patterns of yolk are seen in the post chemotherapy setting. So it is something to watch out for in patients who have been treated. And then a newer stain that's being used now for yolk sac is FOXA2 by Andy's group. It is the new kid on the block. And when you have, I mean, this is pretty classic for yolk, when you have like the endodermal sinus appearance here, and then all of this lacy pattern with these thin strings of delicate tumor cells. This is pretty good for yolk, and for FOXA2 is highlighting that. Going back to the algorithm, here we get the OC34 and it is negative, and then we think about yolk. And when we do AFP, Lipican, keratins, and FOXA2, this highlights the yolk component of our tumors. Again, final description, yolk sac. As we all know about the Schiller-Duval bodies and elevation of AFP. Again, the new kid on the block is the FOXA2 stain. That's something, I mean, it's not available where I do work, but I usually don't need it. It's most probably something that helps in the post chemotherapy setting. The third case is a patient has 32-year-old male has persistent cough, hemoptysis, weight loss, clearly something that's affecting his lungs. Here you see the beta HCG is elevated drastically over 100,000, and AFP and LDH are normal. Multiple no lung nodules are seen. And the first, of course, we do an ultrasound to find a large testicular mass. And the gross examination, you can see a hemorrhagic mass here. And it's well circumscribed, pretty limited to the testes at this point. And you can see the choriocarcinoma, right? So you have a large pool of hemorrhage, and it's just like a cystic space which is lined by these tumor cells. What are these tumor cells? There are two types of tumor cells in the choriocarcinoma: the syncytial trophoblast cells and the mononucleated cytotrophoblast cells. The syncytial trophoblast cells are these ugly multinucleated large cells, and then the base of the lining is formed by the cytotrophoblast cells, which are these almost squamoid appearing um, not multinucleated cells. And sometimes they can be clear, and sometimes they can be really eosinophilic. So this is what you need for choriocarcinoma. You're going to have the hemorrhage with the lining cells that are the syncytial trophoblast and the cytotrophoblast. And the stains that we typically use are beta HCG, GADA3, and P63 to highlight the choriocarcinoma component. So this is a trophoblastic tumor, and the other trophoblastic tumors that we don't encounter frequently are the PSTT, ETT, and cytotrophoblastic cystic trophoblastic tumor. So I'm going to just talk a little bit about the cystic trophoblastic tumor in the slides coming up. And again, sorry, this was the final report on this case. The patient, there was LVI, there was GCNIS, so this was staged as PT2. Again, very rarely you see the other trophoblastic tumors, typically in the post-therapy setting. Okay, so this is the most easiest of all of the testicular tumors. Here you bivalve testis to see multiple cystic spaces, and you know you're dealing with teratoma, and this is possibly all of the keratin deposit from the teratoma's secretions. And this is a classic one where we see the keratin whorls, you see some cartilage, and then you see some end uh, gastric type lining of some of the cystic spaces. What I also sometimes see is this myoid proliferation, and there are no mitosis. They do definitely have some atypical nuclei, and that is totally in the realm of normal for the teratomas. So this is no mitosis. This is not a rhabdomyosarcoma. This is just a teratoma with rhabdomyomatous differentiation. And I ultimately just sign these out as mixed germ cell tumor with the teratoma component, seminoma component, and membranal, as there was in this case. And there was no LVI, so we staged it as PD1. Just jumping to the hot topic of teratomas, which we are all worried for, is teratomas with secondary somatic malignancies. So you have a secondary somatic proliferation, which is which we have an overgrowth of, which basically means it is greater than 1,4x field, low power field, or it's more than around 5 millimeters in size on one slide. And these are typically seen more commonly in the metastatic teratoma setting, where the chemotherapy induces selection of the aggressive somatic clones. So, most commonly seen in the metastatic tumors, rarely also seen in the primary setting. So, when you have a RPLND, retroperitoneal lymph node dissection, that is the reason the urologist is doing the resection, is to see if there is any secondary somatic malignancy, because the chemotherapy typically takes care of
बहुत हुए
uh,
हैं
the chemotherapy typically takes care of. Can you please silence your phone? Um, the chemotherapy typically takes care of the seminoma, the embryonal, the choreo, and the yolk sac. What is the last component that is terminally differentiated? The teratoma. The teratoma is unaffected by the chemotherapy, but what is left residual typically in these RP-LNDs or post-chemotherapy masses are the teratomas. And the teratomas typically in this setting can give rise to a secondary somatic malignancy. So you can have growth of sarcomas arising from uh, a teratomas in the post-chemotherapy setting. The most common secondary somatic malignancy is a sarcoma, and typically it's a rhabdomyosarcoma. The other tumors that can arise are adenocarcinomas, squamous cell carcinomas, more commonly. But sarcoma is the most common. And here you can see these rhabdoid cells, and here you can see the abundant mitoses. These are images of atypical mitosis, and this is not what you want to see. And another setting we had an entire mucinous adenocarcinoma growing out of a teratoma in the post chemotherapy setting. And we did send this for a fish for isochrome 12p, and this was confirmed. So the secondary somatic malignancies do have the fish isochrome that they carry from their germ cell parents, and these do not share any genetic overlap with the somatic counterparts. So a classic colonic mucinous adenocarcinoma does not have any overlap with this secondary somatic malignancy. Other tumors sometimes seen uh, is these small round blue cells. Okay, so there's a little bit of history here, and the previous name, they used to be called as peanuts, right? So peanuts um, were believed to be separate from Ewing sarcoma, but in the last few years, last decade or so, a lot of work has been done on these, and they have figured out that the peanut is very similar to the Ewing sarcoma, and they are on the same spectrum with the same genetic alterations. So the name so there was more work done on this component of the testicular tumors, and they realized that this has no overlap with the Ewing sarcoma or the peanuts, and this has now its own entity called ENT, embryonic type neuroectodermal tumor, which is unique to testicular tumors, especially in the post chemo setting. I also had one crazy case where there was a Wilms tumor arising out of a secondary somatic malignancy out of a teratoma. Another case. So this is a 35-year-old male status post orchiectomy for germ cell tumor. Now he presented with retroperitoneal lymph nodes. So he underwent chemotherapy, which is 4 cycles of BEP for the metastasis, and now I have received the RPLND specimen. In this case, the RPLND had all of the cystic spaces, so right away I knew I was dealing with a teratoma. But the unique thing about this was the cyst wall. The cyst lining was these clear cells. In some areas they were clear, some areas they had these, very adenosquamous kind of proliferation. They were P63 positive. Um, and then GATA positive as well. So these tumors, I have a lot of it from the WHO out here, but these are the cystic trophoblastic tumors. So these have been misclassified several times, and there's a paper from Dr. Yulbright about it. You do not want to misclassify these, because cystic trophoblastic tumors is a very good prognosis for the patient, versus calling these a secondary somatic malignancies. Some of these have been called adenosquamous or just adenocarcinomas, but you want to be very careful, especially in the background when they are very cystic with these lining, where you can definitely classify them as cystic trophoblastic tumors. They have very good prognosis. The patient does not need additional management and can just stay in surveillance. And so this is one of the trophoblastic tumors that you do see in the frequently in the post chemo setting, uh, whereas the ETT and the PTT are far more rare. Again, more details on those, and this is supposed to have a PowerPoint. I don't know if you're going to be able to see this. Here you can see the cystic trophoblastic tumor having hyperchromasia and atypia, um, and then the HCG was positive and the GATA3 was positive. I'm not sure if that came through as a slideshow, but these tumors are cystic trophoblastic tumors. I'm going to be wrapping up soon. Again, going over the entire algorithm, you start with OCT34 in a testicular mass. You can start with SAL4 in lymphadenopathy. Positive OCT34, you deal with seminoma and embryonal. In a negative setting, you're most likely dealing with yolk, choreo, trophoblastic tumors, or teratomas. The second part is the second part of my topic is a quick assessment of tissue biopsies from retroperitoneal lymph nodes. We get this pretty often, and this was a 64. I'm not lying. This is a 64-year-old male, and they were completely suspecting lymphoma or sarcoma, and we got a biopsy. And I'm sorry, not even a biopsy, an FNA. I do also cytology, so I received this as a retroperitoneal mass FNA, and I was pulled to these nucleoli, which I use very frequently. As I said, they are not round, they are not ovoid, they are very stretched out and irregular. And then you have this classic background of glycogen smeared on there. This is called a tigroid background, and these large monomorphic cells and then stripped out nuclei with irregular nucleoli. The tigroid background was classic for seminoma on the smear, and then when you had the H&E of the FNA, you can see the two cell population. One is the tumor cells, and the others are the lymphocytes. And when you did the stains, the SAL4. In this setting, metastatic tumors, I will do the SAL4. The OCT4 was positive and the CD117 was positive, nicely pointing to the diagnosis of a seminomatous component. So what I'm biopsying here and seeing is the seminomatous component. Could there be other components in the mass? Definitely. So that's why I call this seminomatous component of germ cell tumor that's being identified on this biopsy. So of course, right after the diagnosis was made, they did the ultrasound of the testis and they found a small hypoechoic lesion, fibrotic scar-like lesion, atrophy, microcalcifications. They did not describe a mass. Okay, so then we end up getting the orchiectomy, and you see there is like a whitish area here that looks like a scar, and that's about it. There was no mass, and what we saw in histology, as you can imagine, was these are the atrophic tubules, some inflammation, and there's a big, large fibrotic area of a scar, the lymphoplasmacytic inflammation, microliths either inside the tubules or coarse micro calcifications outside of the tubules. And then in the background, we were lucky enough to find GCNIS, but in this condition, only 50% of the cases have GCNIS, and this is what we call the regressed germ cell tumor. And as I am noting here, if you have a situation where the orchiectomy it has a scar, calcifications, necrosis, inflammation, but you do not have, but you have GCNIS, then you can confidently call it a regressed germ cell tumor. But if there is no GCNIS, we typically call it cannot exclude regressed germ cell tumor because um, it could be a viral orchitis, it could be a tuberculosis infected orchiectomy. But in the setting of no, I know I have a retroperitoneal mass here, but in the setting of no mass, I will call these regressed germ cell tumor. Cannot exclude regressed germ cell tumor. If I have a retroperitoneal mass with serum markers and a history of germ cell tumor, I'm confidently going to call it regressed germ cell tumor. So this case, because we had the retroperitoneal mass with the tumor, I was able to call it regressed germ cell tumor, and in this case, we also had GCNIS. If I did not have GCNIS, I would say cannot exclude regressed germ cell tumor. If you have the evidence of germ cell tumor, you can definitely call it regressed germ cell tumor. So some pitfalls in this setting is, especially in the metastatic setting, where we always tend to get a keratin CK7, CK20 in most of our cases. There are a subset of seminomas that can show some keratin staining. So almost always, please, when you have a male patient retroperitoneal mass, ding, 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 you have to think of germ cell tumor metastatic, especially. OC34 is definitely something you should include in the panel along with your keratin. So then quickly take home points, finalizing this talk. There's a lot of growth and development and life curing history in the germ cell tumors past. Before it was a death sentence, very few patients would survive, but with the advent of chemotherapy, cure rates have gotten over 95%. And it is the only thing that needs to be done is we need to think about germ cell tumors in, especially in the metastatic settings. We need to fix the tumors really well. We need to use our IHC very consciously and using this systemic algorithms. I think we would really do a benefit for our patients. And that is the end of my talk. Sorry, I ran over a little bit. Hi.
Hi. Yeah. Thank you so much, Dr. Shivani.
Thank you, Dr. Shivani, for an excellent presentation. I think we are open for questions. I didn't see any question in the chat box. Dr. Anandi, are you seeing any questions?
I'm not seeing any
Not
questions
seeing any
either.
questions either.
So my email is right in the first slide. So if anyone wants to talk or discuss or has any questions, you're more than welcome to send me an email. I know it's a lot of information, but I try to keep a lot of information so that anyone who wants to refer back to it can refer back to it. Sorry again for starting a little bit late and going overboard. And again, all of this is in memory of Sambit. He always encouraged the love for the subject and to learn about it. He always encouraged me to read more. Of course, that's always something you hear from your mentors: read more, read more. But I'm very thankful for his presence in my life. Thank you, everyone.
Same here,
Thank you.
Dr. Shivani. Thank you so much for being here with us today and enlightening us with such good cases. I think the best part was that it had cases that were discussed, so they'll remain in our memory for more time. Thank you so much.
Exactly. Thank you. Thank you, everyone.
The next session will be on 17th. It will be by Dr. Ayman Haider at the same time, an update on neurosave study results. So thank you very much.
Yes, thank you. Thank you, Dr. Bedi. Thank you, Dr. Shivani Kandukuri and Dr. Shivani Sharma. And we hope you'll join us for the next one, yeah, on the 17th.
Thank you, Dr. Anandi. Have a great evening. Bye.
Thank you. Bye.